Whether it's our own personal experience or supporting family and friends, mental health affects us all. Our world-leading researchers are working hard to understand the causes of all types of mental health problems at the National Centre for Mental Health. We're studying how things like our environment, life experiences and genetics can impact us. Over 20,000 people have taken part, with more people getting involved every day, most of whom have experience of living with mental illness. We're keen to hear from as many people as possible so we can better understand the fundamental causes of mental health problems. By understanding the causes, we hope to improve diagnosis, treatment and support for everyone affected. To help us learn more, head to ncmh.info/take-part.
Excellent, thank you very much, Kat, for that. So if I can start sharing my screen now, hopefully. Shout out if you can't see that. I'm going to talk for the next 10 minutes, 15 minutes or so, saying something about the first 10 years and looking towards the future of what we can continue to do in NCMH. So NCMH is a centre that's funded by Health and Care Research Wales, by the NHS R&D funding, and it's there for infrastructure support to support research activity in mental health in Wales. Been established now for the last 10 years, first founded in 2011. At that stage, it was the only Health and Care Research Wales, or NISCR as it was then, centre. There have been some really big and important changes that have happened over the last 10 years, not least is that in 2015 it moved from being a centre involving researchers, clinicians at Cardiff University only, to be a collaboration between Cardiff and colleagues in Swansea and in Bangor universities, and we're going to hear from our colleagues from those universities about the fantastic work that they're doing in a little bit. We're really delighted that we've been, in the last 18 months or so, funded to continue the work of NCMH to 2005. And actually, if you had to summarise what NCMH is mainly about, I think it's the link between the research community in mental health in Wales and the NHS to people with lived experience of the conditions that we study and the wider Welsh public for a range of activities. I'm going to say something about that range and they'll be picked up in the talks this afternoon, and that's for recruiting for studies themselves, for knowledge transfer, for engagement, and importantly for involving people with lived experience in the whole process of research. And we're moving in that direction slowly, perhaps more slowly than we'd like, but we're going to hear from Alan and Sarah later about that important aspect of activity. So this is I don't know what we call it, it's an infographic that we produced for the new grant application. We've moved on some way since then, and I'll point out some of those ways, but it kind of shows you the breadth and the depth of the activity that we have in NCMH, with a large amount of science being supported, papers published, grant incomes being brought in, a lot of involvement, engagement, and other activity. If we had to identify what the key aims of NCMH are, we've kind of written those down, and I think they're summarised in these 3 bullet points here. We're about advancing mental health and learning disability research in Wales to support the areas of existing excellence that we have in Wales, but also to develop capacity in new areas. I'm going to show you an example about how NCMH is doing that. We're about engaging with people with lived experience, their families, the wider public, third sector organisations, to increase understandings of mental illness and learning disability, but also the need for research in the areas. And the last aim we've got there, if you like, is our really long-term goal, which is doing something to change the culture in health and care and social care services in Wales. We're to really make us in mental health services more like other areas of medicine, like cancer, where participation in research is the expectation, that where services are really keen to get people involved, to give people the opportunities to participate in research, that because we know that this is how we're going to generate tangible benefits for people with experience in these areas. So those are our aims. How we do it is summarized in this graphic here. We have three main work packages: building cohorts of individuals for research. I'm going to say something more about that. And then John Bisson, fantastic colleague, is going to talk about our intervention development work later. And John is going to talk about our work with SAIL and other electronic data linkage. But as well as those work packages, there's also those kind of cross-cutting areas that are in the graphic around the edge, you know, because having engaging participants, yeah, and the public, involving people with lived experience, informing policy, knowledge transfer, these are all very vital and important aspects of our work as well. So I'm going to talk about two of the core areas of activity. I'm going to say something about the NCMH cohort, and then I'm going to say something about our involvement engagement activity, but pointing, you know, knowing that Sarah and Alan are going to talk in much more detail about that in the talks to come. So we've been fantastically successful in building the cohorts of people who are helping with our research. This is kind of the NCMH team when we reached the 20,000 participant background and barrier, and now we've recruited over 22,000 people who have participated in NCMH research. And our participants, we consent them so that we can keep in contact, that we can go back to them, ask them to participate in further work if it's something that they want to do, and also consent them that we can, through SAIL and other routine data linkage, we can conduct research in that area. We recruit very widely, not just through NHS services, but through third sector, but also directly accessing and appealing to the public. And over the last 5 years or so, we've developed two new methods of recruitment. It used to be that our team used to go around and do all of the interviewing, but now we're doing more work online, which is proving very successful, but also working with local R&D staff in the Welsh Health Boards and in the NHS trusts in England, yeah, getting the involvement of local staff in order to do the ascertainment and recruitment. That's proving very successful. I just wanted to give you a picture of the range of activity now that we've got going on under NCMH. In the first few years, first 5 years really of NCMH, we had kind of one NCMH assessment that we would members of the team would go out, ask people to participate and conduct a brief assessment with them. Actually, that's how it started. This is how it's going now. And this is kind of more recently shows you the number of different assessments and studies that NCMH is involved with, where across the age spectrum, from studies of ADHD in children through adults into old age, and in a range of particular conditions and areas. So that just wanted to show that, I'm not going to talk about it in detail, but just to give you an idea about the development and the complexity of the research and the number of different studies that is going on now at NCMH. The other example I wanted to talk to you about when it comes to kind of building cohorts for research is our work in reproductive mental health. And I think this is a really great example about how NCMH can support and develop new areas of activity. We've always had an interest in postpartum psychosis, through my research and others. And actually, what we've been doing in recent years is expanding that, developing into new areas of reproductive mental health, including looking at the impact of menstruation and menopause on women's mental health. And in doing that, we're developing future research leaders as well. And yeah, I'll give you an example of my fantastic colleague, Ariana Di Florio here, who's been incredibly successful building work in this area. In NCMH, we've provided the infrastructure for Ariana and her team to do her work, the involvement in structure, the ethics, the R&D approvals, the protocols, the data collection, the databasing, sample curation, all of these we've been able to provide. And that's really provided opportunities to develop new work, new cohorts, new opportunities for impact. And the other point is it's really been very productive as far as leading to further funding, with now over 2 million of new funding being brought into Wales to do this work on the back of those developments that we've made in NCMH. And I think that's a really good example of the model that we're going for. Using the infrastructure that Health and Care Research Wales funds us to develop areas of activity, bring in new funding, and doing this really vital and important work. As I said, another really important area of NCMH activity is in the area of involvement and engagement. I'm not going to say a huge amount about this because I know that Sarah and Alan have got a slot after the break where they're going to talk to you in much more detail about this work. But just to say that the involvement, the input of people with lived experience is absolutely vital to everything that we do at the National Centre for Mental Health. And we're really keen to recognise that people with lived experience help in different ways. That can be formal involvement, research activity, right from the start of inputting in research ideas through into programs of work. And Alan and Sarah are going to talk to you about the fantastic PAR group and their activity, but also in engagement. We've got a fantastic group of research champions. I think we're going to show a video from one of our research champions after my talk. And that is a really important area in which people with lived experience help us as well as participating in the research itself. And I think it's really important that we recognize these different ways in which we interact and get the help and the involvement of people with lived experience. Alan and Sarah are going to talk about our involvement activity, just to say that engaging with the public, engaging with patients and carers, people with lived experience is a vital part of what we do. And again, this is an infographic we put together with gives you some taste of the variety of activity, important activity in this area, which really I think is one of the main ways in which we can change that culture that I said is a key aim of NCMH at the start of the talk. Then lastly, I just wanted to say something about the impact of COVID, which has impacted clearly on us all in society, but for people with mental health conditions, the impact has been even greater. COVID has meant that our recruitment into our studies has been impacted and paused and closed down for a period of time, but it also has given us some other opportunities in order to look and to conduct research to address the impact that COVID-19 has had on people with a history of mental illness. Over 3,000 participants helped us with this research, and if you on the webinar today were one of those, huge thanks. And we were able to collect data on a range of areas, including on eating disorder behavior, on sleep patterns, and then there's a lot of work still being done, but I just wanted to show you the first paper that is in press now on this work that looked at a range of mental health outcomes, looking at using some of those measures listed there. And actually, what did we find? Well, we found that of those people who participated in the research, over half of the sample, 54%, said their mental health was worse during the pandemic. And when we control, when we after adjusting for confounders and controlling for a number of factors, we found there was a number of variables associated with worse mental health during the pandemic. Interestingly, because this has been shown in studies of the general population, we found a bigger impact in younger age, perhaps unsurprisingly, but also again important, those on low incomes, those who have been financially impacted by the pandemic had worse mental health. And then some other factors that were really interesting may have been a result of the worse mental health themselves. It's difficult to disentangle that, but those experienced difficulty accessing mental health services, which came through as a real problem for many people. Those that had significant concerns and worries about COVID-19, those that were sleeping less and drinking alcohol or taking drugs more than usual. As I say, those latter ones, that might be a result of that worsening mental health as well as a cause, difficult to disentangle, but that was interesting. But actually, interestingly as well, though those factors associated with better mental health included feeling socially supported by family, friends, and those felt better supported by mental health services. So some really interesting and important results starting to come out there and be published from our COVID-19 work. So I've shown you this before. This is just to finish my talk. This is a summary of the activity of NCMH in this next 5 years, and we're going to hear later about, with more detail, about the really fascinating and important work that we're doing in intervention development, electronic linkage, but also going to hear about the public involvement activity. So if that's a very brief summary of what NCMH has achieved in its first 10 years, what do we hope to achieve in the next 10 years? Well, I think we want to carry on doing what's worked really well. We want to continue to support, and we need to develop more mental health research in Wales, linking it more closely with NHS services, because I think this is the vital task. We want to change that culture in mental health services, so research becomes a really important part of the activity of the service. We want to expand our involvement and engagement activity, and Sarah and Alan are going to talk a little bit more about the really exciting plans that we have in that area. We're going to focus our participant recruitment rather than being very general, really focusing our areas of strength and where the investment will be most beneficial. John's going to talk about intervention development. And then the last thing I wanted to put, because I think this is really a fantastic opportunity, bringing together some of the this MRC Centre for Psychiatric Genetics, the fantastic group up in Bangor on looks at social models, really taking that psychosocial model seriously, integrating these different perspectives, because it's only then, I genuinely believe, that we can make the major advances that are needed to really improve the lot of those with lived experience of these conditions. So with that, I'm finishing, and I think I'm handing back to Kat to show you a video from one of our fantastic research champions, Laura.
Hi, I'm Laura, and I'm one of the mental health research champions for the National Centre for Mental Health. I really feel that research is important because that's how we learn about things. And when we learn about things, we're less scared of them, which reduces the stigma, which is what this is all about. We feel as a family how this is so important. And we stand by that, by the fact that we were the first 3-generation family, my dad, myself, and my son. We really want to give as much to the research as we possibly can. We feel that when we give our DNA, there's a chance to see whether this is genetic, and being the same family line, that's awesome. I became a champion because I fully believe in research. I fully believe this is how we're going to make a difference. By learning about things, we become less scared of them.
Excellent. Great to hear from Laura then, who's been a fantastic support and collaborator with our research for many years. So with that, we're going to hear now from some of the fantastic groups and activity that I referred to in my talk. First, we're going to go up to Bangor and hear from Anne Creyer about the work of the group there. Anne, you okay to take over? You got slides?
Yes, I have. Thanks very much.
Fantastic.
I'm just
Hopefully you'll
going
be able to share screen. Yeah.
share my screen now. So
Thanks,
hopefully,
Anne.
great. Thanks very much. So my name's Anne Creyer and I'm based in Bangor University in the School of Medicine and Health Sciences. And I'm a member of the Centre for Mental Health and Society and have been since it started. So my colleagues have nominated me to talk today about the Centre for Mental Health and Society and the work we've been up to. So it's just important to highlight, it's such a short time frame, so I'm only going to pick out some examples. So I'm not placing specific evidence on any of the work of my colleagues, or I just won't be able to talk about everything. I'm not sure if you're familiar with the team. So there's not everyone here, but you might know Professor Rob Poole, Professor Catherine Robinson, Professor Peter Huxley. So Rob and Catherine, I think, were the initially PIs on co-PIs for the National Centre for Mental Health, and they were joint directors for the Centre for Mental Health and Society in North Wales. And Catherine's now moved to Manchester, but she's still strongly involved in the centre. So now Peter Huxley and Rob Poole are joint co-directors for the Centre for Mental Health and Society up in North Wales. Just to give you an idea, the centre was formed in 2012 and it's a collaboration between Bangor University and the Betsy Cadwallader University Health Board. So as I already said, Rob and Peter are the sort of co-directors for the Centre Mental Health and Society. Our group especially has a strong interest in social determinants of mental health and the mental health of marginalised and deprived populations. And I think that links really well in what you talked about, Ian. So I also put up here a book that Robert and Catherine wrote in, I think, 2014, and it's looking at the link between mental health and poverty, looking at the evidence, and that's, you know, still very topical, really. The centre altogether has been very successful in grant capture, publications, and in influencing national and international opinion. So I'm going to talk about some of the examples. So this is, if you go to our website, there will be more information, and this is the sort of how we try to structure our areas of interest. So you can see that's quite diverse, with different people taking forward different parts of the research, and I'll come back to that while I give you some of the examples. I thought it would be good to start off with Peter Huxley, because I know that he's involved in analysing parts of the data, the cohort data that's been collected, and that's looking at childhood deprivation and psychosis. In the data set, there were global quality of life and social inclusion questions or ratings that actually are part of the analysis. And Peter has been involved in development assessment tools for a very long time. And some of you may be familiar with his earlier work on quality of life and social inclusion measurements. So I just listed a few here. So it's been very active. He's also very keen and interested in research on social outcomes. So we recently finished a systematic review around, which has been published in Brain and Behavior, which was looking at schizophrenia and outcomes of schizophrenia, and that updated a review that was undertaken by Richard Warner, who's done some groundbreaking work earlier on, and Peter used to work with Richard Warner, so Peter wanted to update that review. I was involved, but I can strongly recommend it. I think there's some very interesting outcomes. At the moment, we've started working on a new systematic review, again, that's led by Peter, and that's looking at the relevance of the Goldberg-Huxley model, and I'm not sure if you're familiar with that. That's some work that Peter developed, I think it was in the 80s, I'm not absolutely sure, I think 85 or so, looking at models of pathways to psychiatric care. And more recent research shows that this is still relevant, really, and we just want to see and look at different elements of that and look at how that links into research literature that's around and how relevant that is in some of the areas that we're looking at today. Then moving on to Rob Poole. he's got a particular interest in pain management and opioids. So he's been involved again in a wide range of projects, and that's just some examples. So is there something about the implementation of the Berwyn Medicines Management Policy? And I'm not sure if you know that we have got a big prison up here in North Wales. Also looking at prison placements for medical students, which is an innovative undertaking for their medical education. He's got various strands of work around the control and reduction of opioid prescribing in primary care, and another project which is a Global Challenge Research funded, so is South Asia Cell Family Research Capability Strengthening Initiative, SASHI, which is a multi-center study working with Pakistan, India and Sri Lanka, and I'll say a bit more about that later. More recently, Rob and Catherine have been involved in writing a chapter for this book here, Mind, State and Society, which is very interesting. It's available for free to download. So if you Googled, if you were interested, if you Googled the title, you'll be able to find that and download it. Just checking, that chapter was called, did I write that down? Yeah, Social Theory, Psychiatry and Mental Health Services. Rob's also very keen on music, and he's got a blog, and that's why I put that up here, which is a bit different. If you were interested, have a look at that. If we move on, then these are two others of my colleagues. So John Bailey, I don't know, some of you might be familiar with John. He works on opioid medication pain related research. So for example, he's working on longitudinal study of high dose opioid prescribing in North Wales GP practices, and they've recently published a paper in the British Journal of Pain. You can see here the other colleague of mine, also a member of the centre, is Satyana Fees. Then we've got Wolf Livingston, who works with in the area of sort of alcohol substance use. So he's done some very important work on minimum pricing for alcohol, and that was for Welsh government, but also Scottish government. He's currently doing some work on substance use in prisons, and that's for the Scottish government. And I thought it'd be interesting as well to see, you know, the range of things that people are engaged in. So here is Wolf up here. He's part of a podcast talking about the substance use and domestic abuse. Another member of the centre is Professor Peter Lepping. And he is a member of the European Violence in Psychiatry Research Group. So that's quite a different sort of approach or strand, if you like. And they work on the prevention of violence and coercion. So he also does other work, for example, on the prevalence of learning disability in psychiatric settings, prevalence of incapacity in emergency childbirth situations and how to improve that, and local work on reducing aggression in healthcare settings assessment tools. He also recently published a paper with colleagues that I thought would be interesting to see, that on the bottom here. Another example, or some other example, relate to my own research. So this is early review of the mental health crisis care concordat in Wales, which I undertook with Catherine Robinson. Another one is a project around vulnerable adults and antisocial behaviour. That was an exploration of current practice. And I just got a snippet here on the right. This is a blog that Philip wrote, and he was one of the service user researcher who was involved in the Vulnerable Adults and Antisocial Behaviour project, and he's written about his experience of participating in the research. And that was a really interesting and very fruitful project, I think, by having different stakeholders working very closely together. It shifted a lot of perceptions and some of the practice. Another project I've been working on was the one around service provision for people with mental health and substance misuse problems, and looking there specifically at stigma and social exclusion, and that was again with Catherine and Rob Poole. So I think thinking about then going forward for the Centre for Mental Health and Society, and again, this is just you know, just a few of the things we're working on at the moment. So we've put in 2 more large project grants proposal for work to continue taking forward work with SASHI. And that's important to emphasize, maybe, that that's not just about work in low and middle income countries, but there's a lot about transferring learning and building research capacity and capability in low and middle income countries and in the UK. We've got another mental health crisis care proposal in the pipeline, and that's working with the Mental Health Crisis Care Assurance Group in Wales. There's some more proposal going forward around prison and mental health work. So there's these are just examples, as I said. I think finally, I also wanted to sort of highlight the importance that building research capacity is a very important element within the Centre for Mental Health and Society. So, for example, there are very close links with the BCUHB, so the Health Board, Mental Health and Learning Disability Academic Partnership Board. And so there's a lot of development supporting research development in the NHS through R&D links. And I think that's very important. That's what Ian highlighted earlier on. Another example is one of our PhD students, and that's Emily. She got a Welsh Clinical Academic Training Fellowship, and she's looking at burns data, some very interesting work. That the data that she's collecting and analysing is part of data that we get from the SASHI project, so from the GCRF grant. She's also linking in to the WHO specific interest group around burns, so that's lots of different networking going on. The Centre for Mental Health and Society itself links to the Offender Health Research Network Cymru, so we host some of their meetings on a regular basis and present in the north and present research there. We also have got something which is called MARS, which Catherine originally developed, and that's methods and research in service settings, and that's sort of a group that meets on a regular basis. And at the moment we've got representatives there from Bangor, Manchester University, for example. We've got service users, we've got representatives from the NHS, and it's about developing new ideas and partnerships and constructively talking through ideas. So yes, I think that's all I wanted to share with you. I think that is sort of, we conduct research on the regional, international and national level, and I think in various areas we're quite a diverse group, and I think that's also very important, interdisciplinary. We come from different backgrounds. So thank you very much. I hand back to Ian now.
Excellent. Thank you very much, Anne, for that really comprehensive coverage of some of the really interesting work, important work that's been done in the Centre for Mental Health and Society in Bangor. I think it's if I just say, I think it's great that we've been able to bring that perspective into NCMH, you know, and I think what the real opportunities are going to be in the future is to integrate that psychosocial, the societal perspective with some of the biological, genetic work that's been a kind of traditional strength of the research groups in Cardiff. So it's great to have you. Thank you very much for that. Just a reminder to everybody, if you've got questions, any questions on any of that work that Anne covered, put that in the question and answer tab, and we'll come back to that in the discussion section later. So thanks very much, Anne. Moving on to another Anne now, but an Anne without an E, and John, who fantastic colleague from Swansea, who is the lead of our data linkage work package and is really leading some absolutely amazing work in Swansea with the SAIL group. And hopefully, Anne, you're going to tell us a little bit about that activity now. Anne, over to you.
Wonderful. So thank you very much for those kind words, Ian. I'm a professor of public health and psychiatry at Swansea Uni. I was a GP in a former life and then did public health. And I work with a team that's multidisciplinary. We work a lot on data. And so we range from clinicians and psychiatrists and psychologists to engineers and computer scientists and qualitative researchers. And it often leads to some very interesting conversations. So the team is very multicultural from all over the world. I'm basically going to give you a whistle-stop tour of the work that we do within the NCMH, where we do it. So I'm going to talk a bit about the Sale Data Bank for those of you that have never heard of it, and then talk about some of the projects that we've been involved with. And I guess because we use routinely collected data, and routinely collected data is the sort of data that we generate as we go about our daily lives. So that could be, you know, I started off definitely in the world of health data. So every time we see a GP or go to A&E or get, or there's a prescription, it generates data. And the work that we do is sort of look at a population level at what that data means. And because it's real, it's what's happening in the real world, it really speaks to policymakers and practitioners. And I think, you know, although sometimes the work that we present is very graph-based and all about big numbers and, you know, sometimes quite complex statistical analysis, the messages, I think, really speak to change. And I think that's not been any more obvious than it has been in the last 2 years. So one of the things that I guess I would say is that, you know, prior to COVID, I think of myself as a clinical epidemiologist. No one knew what an epidemiologist was. I would never have owned up to that. I would have gone, oh, I used to be a GP. Now people do, and people are used to looking at, you know, thinking about R values and looking at graphs. So I do think the meaning of the work that we do has become more accessible. So why is data linkage important? So when you think about people with mental health problems, those who are really experiencing difficulties, so you know, as you know, people with mental health problems, things ebb and flow. Sometimes, you know, things are symptoms and experiences and what you can do can be really severely impaired. Other times, things might be a bit easier. And what you find is unsurprisingly, when people are experiencing adverse outcomes, so when they're not very well, they're less likely to participate in standard research studies, which basically means they do not have a voice. They're also less likely, you know, lots of surveys and things happen in schools, they're not going to be there. So one of the things about routinely collected data is usually people are present in the data that we look at, so it does give them a voice. Lots of standard studies are asking people questions, and as you know, sometimes the meaning of questions is slightly different to whoever you ask them of. Now, you can overcome that by asking what we call standardized questions. Anne talked about one that Peter Huxley had developed, but sometimes the clinical meaning's unclear. And then for many studies, you want to know, you don't just want to know what happened, you know, in that 2 weeks that people were in the study. You want to know what was the effect in a year or 10 years. And people, not just those with mental health problems, but people generally tend to be lost to long-term follow-up. Now, if we can link people anonymously and protecting their privacy into research studies, then they still have a voice and they're not lost to follow-up. So it's sort of, it's part of the picture. There are strengths and weaknesses to all sorts of ways that we do research, but I think data linkage really helps. Now, in Wales, we have an international reputation for being good at this. And that's in the trusted research environments. That's what a tray is. So people used to talk about trays and I'd be thinking, what are they talking about? But that's what it is. It's a trusted research environment. And in Wales, that's the Sale Data Bank. And it's basically a large repository. There's billions of records in there of routinely collected data, health, social care, court data, prison data. We're doing studies in all those areas where data is anonymized but can be linked across each person. So you can really follow someone's life, but you can't identify them. So it's secure, it's safe, and it's private. And we can also link across different data sets. So on my right-hand side, you can see a list of data sets there. Now, those are all routinely available in Sale. And what happens is the identifiable information, so names, addresses, all that sort of information gets split from the stuff we want to work with, and then encrypted with an ALF, which we call a key. So everyone has an ALF. And then within Sale, the individual ALFs can be linked. So there's, it's almost real time during COVID, though that's limited in who can access that. Researchers have training, there's an ethical process, there's a secure remote desktop, and nothing comes out without review. So over time, in Swansea, we've established a team I've talked about. We work in mental health. We work particularly those with severe mental illness, suicide and self-harm, and children and young people's mental health. We work with patient, public and lived experience groups directly, and also we've done a number of national surveys about how people feel about the use of their data with policymakers and clinicians. We've got a particular focus on inequalities and underserved groups. That's my public health background coming out. And we started with code validation. And code validation is basically about how you identify who the populations that we're asking the questions about. And that sort of rubbish in and rubbish out is about, if you don't get that right, then none of your answers have any meaning. And you often hear people talk about that, you can do anything you want with data. Well, you can if you're really bad at it. But if you approach it in the same way that you approach any research, with clear definitions, clear analysis plans, you come up with answers. So this study is one. Now, I'm sure many of you are aware that people with severe mental illness, so predominantly this study was about people with bipolar disorder and schizophrenia. They die up to 20 years earlier than people in the general population. So to me, that is a health injustice. It's something we need to understand. We need to understand the interface between mental and physical disorders and how we can address them. And basically, what we did was we identified people in general practice and hospitals who had those diagnoses, and we looked, one, at what they were dying of. So the circle around this graph, that shows you the percentages of the causes of death in these populations based on the data in Sale. But the radial diagram shows you where it's very different to what's happening in the general population. So we know that things like heart disease, respiratory disease and cancer, that's common across the board. People as they get older, they die of these things. So people with severe mental illness are more likely to die of respiratory diseases by about 3 times. That's a 3.2. But if you look at suicide, in ill-defined and unknown causes, we're talking then at 12 to 13 times more different. So there's 2 ways you can look at these issues. There's that if you address the common things, you'll prevent things in more people. But some of the health injustices are happening in other areas where the differences are so huge. So what this sort of work in SAIL can do is highlight the areas where we need to do more work in practice and policy. So another piece of work we did was look at, we linked educational data and primary and secondary care data. So we looked at absences and exclusions in children from year 6, from basically from the age of 11 to 16. And then looked at what were their mental, and linked it to mental health diagnoses up to the age of 24, because as we all know, people, young mental health problems develop early, but people often don't get seen or get help till they're much older in adult services. And school absences and exclusions have been linked to poor outcomes in later life. So how well you do in school, the opportunities, unemployment and poverty, but mainly in very small studies, mostly based on questionnaires, less than a few hundred people, often in school. So the kids not at school, you wouldn't see. So we did a piece of work where we looked at absences and exclusions in those who were diagnosed during school or up to the age of 24 with a range of diagnoses. And what you see here for autistic spectrum disorder, for depression, for self-harm, we're talking between 2 and 3 times more likely to be absent. And being absent was associated with being a girl, being older, being from a more deprived community. Exclusions, you see a similar thing, except there for self-harm, you see you're almost 7 times more likely to be excluded from school if you have a health record of self-harming behaviour. You're more likely to be excluded if you're a boy, if you're and you're older, and similarly from a more deprived community. So what does that mean? Absences and exclusions are collected routinely in our schools, which means we can highlight kids that are vulnerable using routinely collected data for extra support. It also means that all the work that we do for absences and exclusions to support those children, it's a reframing of it. So if you think of how we do it at the moment, we reward with certificates 100% attendance. So like the kids who aren't in school are somehow doing something that's wrong. And this work reframes that issue into something that is much more about children with problems that need support. And I think that's not rocket science. I'm sure everyone around here knew that anyway. But what this does is it demonstrates it really clearly. So the green lines are showing how much higher exclusion levels are than in the black lines, which are the general population. So we've done similar work looking at self-harm in children, where we identified that whatever the method used, boys under 16 were less likely to be admitted to hospital following going to an emergency department with self-harm than girls. Now, there's a lot out there about how boys and men need to seek help more. But actually, there's also an issue of how when they do seek help, how we might be treating them differently. And the data, shows unequivocally that these things are happening. We also looked at suicide in students, which was very high profile. And what we saw there was, in actual fact, rates of suicide in university students was actually lower than in the general population. Now, if you think about that, that's not surprising, because it's often the more vulnerable young people from more deprived communities who don't make it to university. And they also have more risk factors for suicide. But, any death in a young person is something that we should be trying to prevent. And I think one of the things about universities is they're like a setting where we can do a lot of prevention work, because they're all in one place. Got a couple more slides, Ian. I know I'm at 2 o'clock. So we looked at what happened during COVID. Now, if you remember, there was suicide and self-harm were used by a lot of anti-lockdown proponents as a reason for us not to have stay-at-home orders. Now, and there was lots of anecdotal evidence from people on the ground that numbers had increased. When we actually looked at it, and this is replicated in many places around the world, so these two dips that you see are the first and second waves of the pandemic, and you see a reduction in numbers and proportions of those self-harming and attending healthcare settings. However, the drop in proportion was less for self-harm than for other conditions. People were protecting the NHS and didn't want to catch COVID. And we think that difference in proportion, that it didn't drop so much proportionally, is why people felt that there were more there. So there were more, people not presenting with injuries and cancer and heart attacks than there was the drop in self-harm. And we fed that into, I guess the conclusion from that is that there will be a lot of people who were not assessed because they didn't present, which means they didn't get a psychosocial assessment, which is where you identify people's needs. And what that results in is that there may be a lot of unmet need out there in terms of people's wider problems not being identified and helped with. So as part of this, we're part of a team writing a scientific brief for the WHO. So where are we going from here? We've got, we're doing work with the NCMH cohort where we're linking the genetic data with the routinely collected data, so we can look, we call it deeply phenotyping. We can look at the sorts of conditions and things that happen to people in their health records and link it to genetic data. This is, we published our first sort of exploratory study. There's more to come. We're also working on looking at self-harm in prisoners, looking at parents and children in family court data. For many children, that's a huge life event, and we know a fair bit about those in public proceedings, but very little support or knowledge is there about people going through private proceedings. We've linked to university students. There's a wealth of work going on, and we'd be very happy to talk about it more. Okay, that's me done.
Anne, thank you very much for that really comprehensive and amazing account, actually, of the breadth and depth of work being done in this really important area, which is taking advantage of the routine data that's collected. And I think it's likewise, like I was saying with the other Anne, it's amazing to have that collaboration and that work that you're leading being an important aspect of what we're doing in NCMH. So that's fantastic. I think we'll take a 10-minute comfort break now. So let's be back if we can at 1/4 past. It's just gone 5 past now, I think, on my clock. If we can be back at 1/4 past, we'll go on to the next fantastic speakers. Remember, stick your questions in the Q&A box, and we can cover them in the panel later. Anne and Anne, fantastic to talks, and hopefully we'll see you both later in the panel. Welcome back, all. With a fantastic first session. I'm sure the quality of the speakers this time is going to continue that. First up, I'm delighted to introduce John Bisson. John, are you with us? John is a fantastic colleague, professor of psychiatry at Cardiff University, world leader in traumatic stress, and leader of our interventions work package that he's going to talk to us about now. Over to you, John.
Many thanks, Ian, and yeah, thank you for the kind introduction. So what I'm going to talk to for about 10 minutes or so is the intervention development work package. As Ian says, this is one of the 3 work packages, work streams now within the National Centre for Mental Health. And our overarching aim is to facilitate the development and evaluation of interventions to prevent and treat mental disorders. So Dr. Catherine Lewis, who's a research associate with NCMH, and I are the 2 sort of key people, I guess, working within this work stream, but we interact widely with other people across the NCMH network. And one of the groups we work with most closely is the Public Advisory Group, who advises us on all our work within the traumatic stress research team. And a lot of our intervention development work, as we'll go on to discuss, is around post-traumatic stress disorder at the moment, although we're very keen to expand that out. So what we're aiming to do within NCMH is to increase our applied research portfolio. And by that, I mean that we want to take some of the findings that we get from our epidemiological work, if you like, and the data linkage work that we've spoken about, and think how we can use some of that information to better develop and design interventions that can really make a difference to people in the future. So there are particular funding schemes that we're targeting to try and get funding to support this work. And the National Institute for Health Research, which a lot of you will be familiar with as a main funding body, based in England but brought into by Wales, has a scheme called the Evaluation Trials and Studies Scheme, or arm to its funding portfolio. And those are the sorts of grants that we try to obtain to do this work. Another thing that we're very keen to do is that once we've done the research, developed interventions, and hopefully shown that they can be effective, is to disseminate and implement them into practice so that we make a real difference to the health and well-being of people experiencing mental health issues. And then finally, our aim is to ensure participation opportunities are available across Wales. So we want to make sure that wherever you live in Wales, you do have opportunities to take part in research. And I think the NCMH cohort study, which Ian mentioned in his talk, is a real good example of that, where we've got people from all over Wales and everybody has access to joining that. So I'd like to give you just a sort of quick whistle-top tour through what we're doing at the moment, just to give you an idea of the sort of things we do. So on this slide, you can see various sort of acronyms and names of things. The ADEP study is a study looking at the treatment of depression in people with psychosis using a drug called sertraline. This is a study led by Birmingham University, and it's due to open in South Wales later on this year. The TAPER study is a similar study. It's using sertraline really to sort of manage symptoms of anxiety in people with early onset psychosis. And that's a study that's now open and recruiting in both Cardiff and the Vale of Glamorgan University Health Board, and also in our Bevan University Health Board, so the health boards in the southeast of Wales. The CLEAR study is a randomised controlled trial that's led by King's College in London, and that's looking at clozapine in a randomised controlled trial of clozapine for people under the age of 25. So this has been a big research question around for some time for younger people experiencing psychosis who haven't seen their symptoms improve significantly with sort of other treatments, seeing whether clozapine can actually precipitate a greater improvement in their symptoms. I should have said, by the way, that TAPERS is actually led out of Cardiff University by Jeremy Hall and James Walters. The Wolfson Centre is a centre that's been funded in Cardiff University and has very strong links with the National Centre for Mental Health. This is a centre that focuses on young people's mental health, and several people talking today are involved to a degree in that centre. And we're supporting work to develop a randomised controlled trial to prevent depression in children and young people who've had experience of depression and have parents with experience of depression as well. Prolonged grief disorder is something that we've developed a significant interest in, and on the back of some of the tragic stories we've heard through the COVID-19 project, the Welsh Government have funded us to a degree to develop a guided self-help intervention. So this is work that Catherine Lewis is leading on to try and develop a guided self-help intervention to help people with their prolonged grief disorder. Guided self-help is something that we're very keen on. We're working and developing in other areas. So for complex post-traumatic stress disorder, we're developing a guided self-help intervention based on a treatment called STARE narrative therapy, which was developed for survivors, adult survivors of childhood abuse and interpersonal trauma. And this actually looks at not just dealing with symptoms of post-traumatic stress disorder, such as nightmares and flashbacks to traumatic events, but also dealing with some of the symptoms that we term as disturbances in self-organization. So difficulties regulating emotions, difficulties with interpersonal relationships, and negative self-concept, often people feeling worthless, guilty, shameful for things. And we're developing a guided self-help application that will help with that. SPRING has been one of our biggest trials. This was funded by one of the NIHR schemes I spoke about, the Health Technology Assessment Scheme, and we've just completed a large multi-center randomized controlled trial with 196 participants across the United Kingdom. The majority of them came from Wales, but we also had centres in and around Edinburgh, and also Coventry and Warwickshire and Manchester too. I'll come on to talk about that a little bit more. You might recognise this gentleman, but this is a study that we're about to embark on to look at eye movement desensitization reprocessing as a treatment for post-traumatic stress disorder, delivered either face-to-face or remotely. As with a lot of people, we've got increasingly interested in delivering psychological treatments remotely during the COVID-19 pandemic. And this would be a trial within veterans, presenting to veterans NHS Wales across Wales and randomly allocating them to receive EMDR either remotely or face-to-face, subject to pandemic restrictions lifting in a clinic. This is somebody called David Muss, who we're working with very closely at the moment, doing a randomized controlled trial of a technique called the rewind technique, again, a treatment for post-traumatic stress disorder. And we've recruited 35 people into a randomized controlled trial for this intervention. And I think it's certainly the first trial I've ever been involved in, but we've recruited everybody. We've performed all assessments on everybody, and we've treated everybody totally remotely. So nobody has met a participant face-to-face in the study. Everything has been done online. And then finally, the ATP study is a study looking at an anti-inflammatory drug for the treatment of depression. This is a study led out of Cambridge University, and one where we have some sites in Wales that are looking at recruiting people in. A big part of our work, as I mentioned, is dissemination and implementation work. So we're very keen to make sure that actually research results and the evidence base is utilized in a way that means that people can benefit from it. So we spent a lot of time as a group doing systematic reviews and meta-analyses on data. And by that, I mean looking at all the research trials that have been done in a particular area using an appropriate design, and then trying to group all of the results together, meta-analyze the results to give us an overall picture of what the research evidence says when you synthesize all the results from the well-designed studies. Several of us were involved in the development of the International Society for Traumatic Stress Studies, treatment guidelines for the management of post-traumatic stress disorder. And some of us have also just overseen the development of Matrix Cymru and Matrix Plant guidelines on post-traumatic stress disorder treatment for both adults and for children. So these were published in September 2021, so within the last month, and they're available to be downloaded from the Public Health Wales website. And for anyone that's interested, they give you what we believe are good recommendations for the management of PTSD in children and in adults based on the current evidence. I showed on my first slide the group education program for people with bipolar disorder. This has clearly been a major product that's come out of NCMH, and one that's being disseminated very widely and implemented within the United Kingdom. A lot of people are taking part in online courses now, and so this is a really good example of an area of implementation that NCMH is overseeing. We've developed treatment guidelines based on the evidence for post-traumatic stress disorder, and in conjunction with Traumatic Stress Wales, a quality improvement initiative to improve the health and well-being of people affected by post-traumatic stress disorder and complex post-traumatic stress disorder. We're trying to disseminate this across Wales so that wherever you go in Wales, you can expect to be offered treatments that are based on the best possible evidence. And I said I'd mention Spring again, our guided self-help intervention for the treatment of post-traumatic stress disorder. We're now disseminating this, and we've trained up around 50 different practitioners in Wales to date in the delivery of this guided self-help intervention, which increases choice for people with PTSD, and also provides us with a more stepped approach to treatment that is more cost effective perhaps than offering everybody face-to-face therapy over a more prolonged number of therapist contact sessions that are needed with a guided self-help. Another thing that we're doing in several areas is producing resources. So this is just one example. We've developed in the last couple of years a booklet on supporting people who have experienced traumatic events, which is accompanied by modules that give actual guidance to people on how to adopt some simple techniques to help, for example, regulate emotions when feeling distressed. So just to give you an example of one of the trials that we've been involved in, and this gives you a bit of an idea of the sort of standard methodology that we're using in several of the trials I've been talking about, is a randomized controlled trial for an intervention called 3MDR for treatment-resistant post-traumatic stress disorder in military veterans. As you can see from all the different logos on this slide, all of our work is very collaborative and involves a lot of different people. So we had 4 different NHS organisations in Wales taking part in this. We received funding from the Forces in Mind Trust, which is funded by the Community Fund, the Lottery Fund, and also received funding from Health and Care Research Wales. We did it as part of the National Centre for Mental Health, and everybody was recruited through Veterans NHS Wales. So I'm going to stop there. I'm going to hand over to Kat or Mike and ask them if they'd kindly play an animation on this as my parting shot, and thank you very much for your attention.
For most people who have served in the UK Armed Forces, returning to civilian life takes a bit of adjustment. But for around 1 in 14 people, this will be complicated by post-traumatic stress disorder, or PTSD. Symptoms of PTSD include being constantly on edge, vividly re-experiencing a traumatic event, difficulties with regulating their emotions, and the avoidance of reminders, which often results in social isolation. PTSD symptoms persist for many veterans, even after receiving first-line recommended treatments. There is a clear need for a new, more effective type of therapy. Researchers and clinicians at Cardiff University and Veterans NHS Wales have recently completed a trial for a new therapy called 3MDR, or Modular Motion Assisted Memory Desensitization
and reconsolidation. 3MDR, which was originally developed by scientists with clinicians in the Netherlands, is based on a combination of virtual reality exposure therapy using virtual reality technology. The therapy involves walking on a treadmill, guided by a therapist, while exposed to a series of images and self-selected music the participant has chosen to represent the traumatic experiences. These are displayed on a large screen. The aim is to reduce the avoidance of the traumatic experiences, a coping strategy that can contribute to the worsening of PTSD symptoms. 42 military veterans from South Wales were recruited for the study. Individuals continued to experience service-related PTSD following standard psychological treatment. The participants were split into 2 groups. Group 1 received 3MDR immediately, and Group 2 after a delay of 14 weeks, with follow-up assessments at 12 and 26 weeks. At the 12-week follow-up assessments, the immediate treatment group saw a 19% greater reduction in PTSD symptom severity over the delayed treatment group. At the 26-week follow-up assessments, the delayed treatment group responded well to 3MDR and the immediate group maintained their improvement. It is important to note that not all the participants responded to 3MDR. Further research is now needed to determine who this therapy is likely to help most in the future. We hope to continue testing 3MDR for military veterans and other people with PTSD. We want to see how 3MDR will benefit people living with PTSD unrelated to military service. The trial was funded by the Forces in Mind Trust and supported by Health and Care Research Wales.
Excellent. Huge thanks to John for that really comprehensive description of some of the really fascinating work that's happening actually in developing new interventions. Just a reminder to add any questions you've got for John on that work into the Q&A box. And moving on now to Sarah Rees and Alan Midal. They're going to talk about a really vitally important aspect of NCMH's work. That's how we involve those with lived experience of mental health conditions in our work. Sarah's been leading on this area for NCMH, which is fantastic, and Alan has a huge experience, is chair of the PAR group, the award-winning and fantastic PAR group, is probably as experienced a researcher, as a service user researcher as anybody you're going to hear from this afternoon, and has been a fantastic source of wisdom and advice for me in my role as director. So I'd like to publicly thank Alan for that. So Sarah, are you going to kick us off?
Yes, I am. Good
Thank you,
afternoon. Okay, so I'm going to speak very briefly to give you an overview of the involvement activities that we do at NCMH before handing over to Alan, who, like Ian has said, is the chair of our lived experience public involvement group, PAR. So Ian shared this graphic with you earlier, but I just want to go into a little bit more detail about all of the different ways that we involve the public with NCMH's work. So in the middle, we have participation at the bottom of that image. And that's probably what most people think of as involvement in research. So being a participant is about taking part in a study, either by an interview or doing a survey, or perhaps giving a biological sample. The second way that the public is involved is through our engagement activities, which is on the right of that graphic. And that's really about raising awareness. And this includes our research champions. And we heard from research champion Laura earlier in that little video clip that she did for us. But the research champions might do things like contribute to writing a guest blog post for us, and also attending events, just to really sort of share their experiences of taking part in research and championing the work that we're doing. So finally, on the left-hand side, we have patient and public involvement, PPI. Now, this is about sort of taking part in activities like reviewing research proposals, coming up with research ideas for areas and topics to explore. And it could end up with full co-production or collaboration where members of the public are actually working alongside researchers to develop something like an intervention. So if we look on the next screen a little bit more closely at some of the patient and public involvement work that we do at NCMH, we actually have quite a few groups for public involvement. So we've got some ongoing groups that are involved in sharing their sort of expertise and personal lived experiences to shape things that we do across a number of different projects and topic areas. So PAR, our Partnership and Research Group. We have YAG, the Youth Advisory Group of 14 to 19-year-olds, which is a new one that was established late last year. And then some of the PTSD work that John has just described to you, they have a public advisory group for that as well. We also have groups that look at specific projects. So it might be one specific project, and an example of that would include bipolar disorder and pregnancy. That was an advisory group that sort of ran on that project. We've got the Engage to Change Evaluation Forum, which I think Steve will be speaking about next. And we also have some work going on in the area of reproductive mental health, which was mentioned earlier as well. So here to tell you a little bit more about one of those groups is Alan, who is the chair of our PAR involvement group. Alan, are you there?
Yes, I am.
We'll stop sharing my screen.
Yeah. Okay. First of all, you'll be happy to hear I don't have a PowerPoint presentation. Part of the reason for that is you can always rely, if you're not first presenting, somebody will say something that triggers a memory. And thanks to Ian for triggering one memory. First of all, I should explain, PAR formed back in 2008. So technically the NCMH are the new kids on the block as far as we consider in mental health research. And I remember the first time I came in contact with the NCMH was at a seminar when all the research development groups that fell under NISCA were presenting. And I stood up and presented and said, this is what we've done. And this little voice from the NCMH chirped in that, oh, we have 6,000 people involved in research. And, you know, that was the start of it, because we had to, you know, explain that participation is not the same as involvement. So I'm pleased to see Sarah in a presentation defined all of them. PAR started off, as you would expect it in research terms, as a poetry and writing group that sort of went rogue before I started. I joined in 2012, and by then it had become mainly service users and carers, but we were starting to see academics showing interest in coming to our group. So and the other problem we had is it started off in Rhondda Cynon. By 2012, we'd spread across the M4 corridor. We had University of South Wales, Cardiff University and Swansea, but nothing in the north. What helped us immensely was in 2015, I think it is, we came under the wing of the NCMH. We are I should explain you, we are an independent group, but we work with the NCMH. It's a partnership, as PAR suggests. And that gave us the ability, it gave us two things. One, it gave us the ability to move and get membership from the north. And two, it gave us a comms team to promote what we did. And over the years, we've sort of built on that. And we are becoming a victim of our own success in one aspect, and I'll cover that in a bit. Over the last 5 years, we've moved into delivering research clinics where the service users from the group give advice to researchers who are putting in bids for research calls. As you see, the latest one is the Research for Public and Patient Benefit. And we've built on this. It's hard to explain. As somebody who's involved in lots of things around mental health, It's a refreshing approach in that PAR is at least 50% service users and 50%, and the rest are academics. That changes the dynamic of the meeting, and I cannot emphasize how important that is, because if we have any service user who do involvement, you're usually in a room in a meeting, there's 20 professionals and you, and there's no way you can influence anything. PAR gives us that power to do that. So I was then asked, what is PAR? Well, yes, it's this partnership, but it's more than that. I heard it called a talking shop, and yes, it is a talking shop, and I have no problem with that. And the reason, I'll give you the reason for that. PAR is made up of individuals, and if you look at the experience of involvement in research that those individuals hold, we've been on 30 advisory groups for research. We've got one who's been a chief investigator through her professional career. We've got 3 research projects where we've been co-investigators, a couple more where we've been service user researchers, and that's great. That's quite a body of work for a small, but essentially a small group. But then it's the other things that they bring. So for instance, currently we are on advisory groups with University of Manchester, King's College London, Cambridge University, University of West of England, which is a bit worrying because they're not in Wales. But we have members who work in or are involved with Health Technology Wales, the All Wales Medicine, and also with user groups in the community. So, I mean, I want to focus on where we go, because the problem we now have is we have all this expertise and experience building in this little group. And so at the last PAR meeting, we decided to make the jump. So in end of November, we have an involvement hub meeting. It's the first one of its kind, I think, in Wales, where we're trying to bring all the service users involved in research to one place to discuss what we as a group want going forward. Because we do not get the opportunities that academics do to meet outside of our individual meetings. And it's important that we get as many people here as we can, because what PAR intends to do is produce a research strategy for going forward. I mean, as PAR, we've got things we want to do. Ideally, we need to strengthen involvement. We need to increase involvement opportunities. We need to move involvement on a long way from where it is in England, because if you look at how involvement is in Wales compared to how it is in England, we are falling behind. I'm sorry to say this, and we need to work, we want to be part of the solution. If you look in England, you're now starting to see service user researchers as embedded as part of the research team as full-time, part-time employment. And of course, you've got the Service User Research Enterprise, King's London, which has been going 21 years, and we've come nowhere near in Wales. So this is a bit of a I know I'm whinging a bit, but this is a bit of a wake-up call. We need to get our act together. So where do we go? Like I say, the first thing to do is we want to look at involvement. We want the involvement hub just to get an idea of where we are, because Sarah's slide showed all these groups in the NCMH. We've never met together, and I think that's a disadvantage, because if you look at all the experiences and knowledge that are held within those groups, to me, they're not groups, they're more a living library of knowledge and experience that we should be tapping into. We should be coordinating, making it better. Now, I know some researchers would say, well, you're getting professionals now. And this is the problem we have in Wales. In PAR, we discussed this back in 2012, is, when you get to, as Ian said, I'm fairly well experienced in mental health, involvement in mental health research. Where do I go? Because technically I'm sitting in advisory groups, which somebody else should be doing. So part of the remit of PAR going forward is to look at some sort of coordination about what's going on in involvement, look at why opportunities aren't being generated. In the research clinics we've had for public and patient benefit, the last two, we've only had one researcher in each. Is that because they're getting their advice elsewhere? Or is it more worryingly, they're not coming forward to put in for funding bids for that pot of money? Because if it's the second one, we at PAR want to help as in any way we can. And ultimately for me, the gold standard would be a service user research unit based at the NCMH. It's not within the realms of possibility, but I think it does mean that we need to change perhaps how we look at mental health research involvement. Of course, we've now got the national standards on research involvement, public and patient involvement. Yes, they're a very good generic set of standards. They don't work for individual research themes, because if you look at PPI in cancer compared to PPI in mental health, two totally different approaches. We need to make sure that what we do in mental health research in Wales benefits both the researchers, enables people to get involved in research, and moves the agenda forward. I would comment that one of the other things that holds us back is this 5-year funding circle. This is a personal view. This 5-year cycle of going for funding. Everybody knows mental health research is needed across quite a wide area of things. We're not going to solve it in 5 years. I would rather see that mental health is funded, not permanently, but on a longer term basis, with perhaps a 5-year strategy of what we look at in the next 5 years, and that those decisions are made jointly between Welsh Government, NHS, academics, and service users. That's me.
Excellent. Thank you very much to Alan and Sarah for that. There's really interesting talk, actually covering such an important area to us. It's an area that in NCMH that we really are trying to take more seriously and trying to move in the right direction, recognizing that there's plenty of work still to be done, as Alan has pointed out. Right, so last talk of the day, but certainly not the least, we're moving to consider the work that NCMH does in the area of learning disability or intellectual disability. Steve Bayer, his fantastic colleague who leads that area of work, and he's going to talk to us about that work, particularly reference to the very exciting project that he's involved with. Steve, over to you.
Thanks very much, Ian. Okay, so this is another area, I suppose, of applied research that's outside the clinical space, and it's employment interventions for people with learning disabilities. And I'll talk about some of the other ideas that are being developed in the learning disability area in due course. Here I'm ably helped by the team of Elisa Vigna, Andrea Meek, and our research assistant, our administrative assistant, Jacob Meehan. If I talk about the employment work first, it's called the Engage to Change project. We helped to design it as a team from NCMH, and it sets out to create and support youth employment for people with autism or learning disabilities. These are people who are not in education, employment or training, and they're 16 to 25 years old. It's been running for 5 years when it should have finished, but because of the pandemic, they've extended us for an additional 18 months, which is very welcome. And it's Pan Wales, funded by the Big Lottery and with involvement from Welsh Government. We've got quite a good collaborative team here with those who deliver the work directly with people with learning disabilities and autism. That's Elite Supported Employment Agency and a Godiad. We've got the major learning disability umbrella organisation for Wales. Learning Disability Wales is our, I think, our coordinator. We're the evaluation team. We have clearly Welsh Government involvement, but also we have All Wales People First as a key partner. And from our point of view, they're also our evaluation partner. And not only did they input into the design of the intervention, they also now sit as a group to look at our evaluation results and put their lived experience into the results that we develop and we publish. The intervention is, I think, a simple one, but an interesting one. In many areas of life, we try to train people with learning disabilities for adult life. And that has been spectacularly a failure in relation to getting people into the workplace. So the model that we've been disseminating and this project is based on is supported employment, which is a place people into the right job match, train them, and then maintain that job with the use of liberal amounts of behavioural psychology input to the training. And as you can see, there's a whole range of bits that are there that involve working with employers, working with families, and many other aspects of work-based intervention. Key to it is a job coach, somebody who can actually transact all of that. And clearly it's a role that requires training. So we've been working for 5 years now, and so far the project has worked with over 900 young people with a range of relevant disabilities. We're not very proud of the fact that 75% of those have been male, even though we've had interventions to try and redress that balance. Even with some emphasis on people with autism, it's still too heavily skewed towards males rather than females. But you can see there's quite a mix of people with intellectual disability, ASD and intellectual disabilities, ASD alone, and other forms of specific learning difficulties. So it's quite a broad church of people with a range of needs that are being worked with. What's been achieved at the end of year 5? Well, one of the schemes is an internship program where people are brought in for a year into a large employer. We've got one in Cardiff University. There are 2 in Princess of Wales, Betsy Cadwallader, Trust in the North. Soon to open another one actually this year in Wrexham. And that's so far, those schemes have so far supported 194 interns for those year placements and generated 320 interdepartmental placements with a decent amount of jobs. About 30% of those people have gone through into jobs. In the main scheme, nearly 400 people have experienced paid work experience jobs for up to 6 months. And of those, 247 people have been found a job, 63. And that's important because generally treatment as normal, if you can call it that, people with learning disabilities in the UK are operating at about 6% of the population getting jobs. I'm also pleased to say that 86% of those jobs are sustained for 3 months or more. It's a low bar, but it's the DWP's kind of standard of a decent scheme. Of course, many people stay in that for much longer. I won't go into it in too much detail, but we're collecting information about employer reactions, about family reactions, the reactions of young people themselves. And by and large, we're getting very good feedback from employers who rate over a whole series of skill areas, whether these people are actually providing good employer skills. And generally, our responses are very, very positive at the work that people do. And also the support is well received, both in terms of the support to the employers to help these people into employment as their employees, and also satisfaction of the young person about how they're being supported. Some good outcomes being delivered for families as well, as you would expect, and also delivering aspirations for people with learning disabilities. We're at a stage now where we've got enough information to start looking at winners and losers and what characteristics are likely to improve or reduce your probability of going into work. One of the things that's been important to us is pandemic learning. Clearly the employment sector was hugely hit in Wales, and our people in the project were also hit. And a whole raft of new interventions were generated at very short notice to actually help people. And there's a list of some of them there, helping employers with furloughing people rather than just letting them leave employment. Developing social support networks just to keep people engaged when they were either laid off or under furlough. Complicated welfare benefits advice to have somebody go out of a job but then come back into a job without being disadvantaged with all of the things that they had in place before. Helping people to travel safely within a COVID environment. In fact, the partners developed a qualification, a recognised qualification in working safely under COVID, which really assured employers to bring people back into the workplace who had a learning disability. Working in new ways, I think, within the workplace in a COVID-friendly way to support people, but also working to support people online. And job clubs and accreditation courses that kept people occupied and moving forward while waiting for jobs to come back. And our big problem now, building confidence for people to come back to work. When you've been in this kind of situation for 2 years, a lot of people are very risk averse, and going into a job still with our welfare benefit system is still a risk. So there's a lot of learning there, but if I summarise it more broadly, if you look at the research in the middle, it's had a number of impacts. We've been able to influence apprenticeships to become more inclusive. With our advice and involvement, we've been able to persuade Welsh Government with others to commission new apprenticeships using job coaches to actually make them more accessible for people with learning disability. In fact, both our partners were involved in that, delivering support. We were able to evaluate that. And also looking at introduction, one of the things that we've got, which is a support grant to support employers in that. So that's now being rolled out more widely after a successful pilot. There's a new kid on the block in terms of employability called Jobs Growth Wales. They're already exploring that in pilots of job coaching to make that set of employability assistance more accessible to people with learning disability, based on some of the feedback and data we've given them, including things called traineeships, and also we're in negotiation with people about a higher number or a greater commitment from the NHS in terms of jobs for people and placements for people with a learning disability. Again, we've contributed to a new service, a supported internships, a bit like the ones that I described earlier, like the one we've got in Cardiff, which are being funded by colleges with a new funding source. And we're trying to make sure that the lessons that we've had over the last 5 years are built into advice for those newly emerging supported internships so that they deliver the quality that we've been able to achieve, I think. Regional partnerships, we're seeing in North Wales a cross-regional local authority partnership that's trying to develop a longer term supported employment service that goes beyond our project that can support people in that region. I've already talked about, in the top left-hand corner, post-pandemic learning about employment, but we've also been able to bring the LD cohort from NCMH into wider research, looking at the experience of people with learning disability of COVID, a one-year research programme led by colleagues at Warwick and also Manchester Metropolitan. So to finish, what's the future? Well, we're hoping to extend the learning disability cohort membership wider so that people can, picking up the idea mentioned earlier of people being a living library, to get more people involved in the kind of cohort model that can help answer more research questions about life and policy and services in the future. We're also looking actively at broadening the NCMH LD cohort to those who experience and who can help us to address more specialist clinical questions. We're hoping to consolidate our employment policy impact into 2022 with our extension. I'm particularly hoping that we can help Welsh Government to bring more NHS engagement online. And we're also looking at new intervention research to support those new supported internship experiments that are starting this year with our partners that we already have a lot of experience of delivering this kind of thing in the future. Thank you very much.
Thank you very much, Steve, for that description of what has really been an amazing bit of work, the Engage to Change project, and I pointed to some of the other directions that we're taking LD work in NCMH. I think what we've got in this last 10 or 15 minutes or so, and we'll try and get everybody off on time at 3:30, is it's down for me to make some closing remarks and then to go to a bit of a panel for the Q&A session. I think what's been really clear to me today, and it's always fantastic to hear the other PIs involved in NCMH talking about their work, is the breadth of activity that's supported in NCMH. I think from the work that Alan talked so passionately about, and the importance of service user lived experience involvement throughout the process, from the work that Steve was talking about with the Engage to Change program, making a real difference for people in the world of work, through some of the big cohort work that we're doing, looking at biological and genetic factors that are proving so interesting and successful, through the work that Anne was talking about with SAIL, through right to the intervention development work and the exciting developments there that John was talking about. I think it's a fantastic range of activity. I think there's a lot for us in NCMH in the first 10 years to be really proud of, and I hope that we can continue to develop the work further to really make a difference for those people who live with these conditions, mental health conditions, which ultimately is how, of course, all this work will be judged. So with that observation, we're thanking you for staying with us and thanking all the speakers for their fantastic efforts today. Let's move to a bit of a panel discussion. There are a few questions that have come in that I'll take. I'll take the most recent one I can see here first. Mental health services are stretched across the board. How can we encourage them to take part in research or innovate practices if they're forced, it seems, to concentrate just on crisis intervention? John, are you with us? You would be an ideal person, I think, to address that question to first. It's a fantastic question, I think, actually, and it's a really important question because we know how stretched the NHS and services are. How can we support services to really focus their activity in research?
Yeah, I think it's a really good question, Ian, so thank you very much for that, whoever put that one down. I think it is difficult. My impression is that there is a real appetite to get more involved in research, and we, through the National Centre for Mental Health, are trying to work with different NHS organisations in Wales to to offer opportunities for people to take part. My view is that we need to try and sort of tie in the research side of things much more with service improvement and audit as a sort of first step to people, so that we can actually do things that people can really see an early difference to their practice. And what we found through some work within Cardiff and Vale is that by expanding a forum that we had called a research forum into one that's called a research and quality improvement forum, we got a lot more engagement by people on the ground and increasing people getting involved. So I can only talk for Cardiff and Vale in this regard, but there's now about 15 active studies going on across a wide range of different areas as well as a really thriving sort of quality improvement arm, which is led by one of the consultant psychiatrists at Cardiff and Vale, who works closely with the people leading on the research. So I think a lot of it is about making things sort of meaningful and relevant to people's day-to-day jobs, that gets people interested in it. And then from there, several people, and we know because several people work with us in NCMH on other projects, people get an appetite to go deeper into a particular area.
Excellent. Thanks, John. Has anybody else got anything to add to that? I think that was a really comprehensive answer. If not, let's move on to next question. This is from Andrea. It's a question for me. Ian, is there an opportunity to include domestic violence into your project? I'd be very interested in this area. I think, Andrea, that's a really important area and a very sensitive area to do research in, and it's something that with the COVID-19 research that I covered briefly in my talk, we did consider and did add some questions about domestic violence, having discussed with people with lived experience, but also with some of the researchers that do work in this area and some of the third sector organisations that work in this area. So it's an area that we have data. As yet, it's not one of the areas that we've looked at that data, but just to say yes, it is important, and it's an area that we have included in our surveys and will be covering, so we can get back to you and share that information. And then last question I've got here is about rural mental health. Question from Alan Woodall, asking about rural mental research interest. Is anybody leading us, given 35% of the Welsh population are rural? I'm a GP, innovative in a new post-integrated mental health in Paris, aiming to build research capacity. I think this is a really important area. I don't think anybody else has any comments to make on that. But certainly we do in our NCMH assessments get information about where people live. So the ability to look at that distinction about whether people are live in rural or cities is definitely something that we're about to address. We've also got a new research postdoc who's based, just recently started, based in Bangor with the team there, that this is an aspect that would really come under his area of interest, and the analysis that he's going to be doing of our data. So Alan, yeah, please get in touch, drop me an email, and we can work out who best in NCMH it would be to link you up with to discuss your interests in that area. Okay. What I'm going to do now, I think, is just give us a final opportunity, if there are no more questions that have come in. I'd like just to go around the panel for some final comments, and I'm going to ask the panel just to summarise, if they could, what they think the main challenges for us in Wales as far as mental health and learning disability research, and what they're most excited about, what are the prospects that really get them up in the morning and they're excited about. So what are the biggest challenges, and what's the most exciting prospects? And I think, if that's okay, let's start with Alan, if that's okay. Alan, what do you think are the biggest challenges for us, and what do you think are the most exciting prospects for research in mental health in Wales?
Unsurprisingly, for me, the biggest challenge is increasing the number of opportunities for people to be involved in research. And what gets me up in the morning is solving the problem. We've got an opportunity. We have the skills in power now. We're going to move forward. The involvement hub meeting, which I think is end of November. Sarah can give a date. That's the first step in what power wants to go and where power wants to move involvement in mental health research.
Excellent, Alan. Yeah, just incredibly pleased to have you along on that journey, working hard. Sarah, do you want to add anything to that?
Yeah, sure. I'm going to just say that I think the biggest challenge often just comes down to the money. Yeah. That's such an important thing to address. And I think there's certainly a lot more funding to hopefully get hold of that will make the rest of it easier. And yeah, the 25th of November is when we're hoping to hold this involvement hub. So if anybody watching this has taken part in public involvement activities for NCMH and is interested in coming along, then please get in touch with us. Please email par@cardiff.ac.uk. Yes, that's all I wanted to add. Thank you.
Excellent. Thank you, Sarah. Steve, let's go to you now. What for you are the biggest challenges? What's the biggest exciting prospects do you think that we have? I don't know if you want to limit yourself to the LD work or your mental health and LD work in general.
No, I'll limit to the LD work. I mean, I think post-pandemic, we've had a lot of services collapse for people with learning disabilities in Wales. You know, we're still holding our end up in employment, but there are a lot of day services and others that have failed really to stand the test. And we're, I think, on the cusp of a new strategy being launched, you know, with great aspirations, but you know, along, you know, the theme with Alan and with Sarah, that we need the consumer voice in this to say, you know, what they're experiencing and what they want. And for people with learning disabilities, that's difficult to do for NCMH because of their lack of ability to contribute, you know, independently to remote data and you know, providing information directly to our platforms. I think we can do more with that. We've had some great input and some engagement through the COVID work that we've been involved with others. And I think that's going to help us to really start to see a whole range of ways in which people and their families can actually contribute to that debate. So I'm excited about the partnerships we've developed in that area and extending them to make sure that that voice is actually heard to improve services in the next few years.
Excellent. I think that's a really exciting challenge, Stephen. Some really fantastic opportunities to follow up there. And then last but certainly not least, John, have you got anything to add about the challenges and the excitement that's getting you up in the morning at the moment?
Yeah, I mean, I think the challenges, I agree with what people have been saying. I think funding is an issue. There is funding there, but we've got to be, you know, sort of quite strategic to obtain that. The other thing that I would bring up is sort of perhaps the approvals system, and just hoping that we can work with people to make sure we're proportionate and that research really is seen as a key mission of the NHS. For example, in the United Kingdom, I sometimes still sense that things are a bit more difficult than they might be to get research, you know, moving forward and done in a timely manner. And then in terms of excitement and getting up in the morning, well, there's plenty to do and plenty of things do that for me, but guided self-help and sort of developing interventions like that I found really exciting recently. And just to pick up on Andrea's point, certainly with our development of the complex post-traumatic stress disorder guided self-help intervention, then you know, people who have been subjected to domestic violence are certainly a part of that research stream. Thank you.
Important. Excellent. Thank you, John. Thank you to all the speakers today. Huge thanks to Kat and Mike and the NCMH team for putting this on, and massive thank you for everybody that's sending that. Now, I'm sure I've missed questions that have come in through the Q&A box and the chat box. Kat, Mike, can we kind of make sure that we go through and see if there's anything's missed, and we can get back in touch with people. I'm going to finish now 1 minute late, but I think it's really important that we kind of finish on time. I'm sure there'll be further opportunities for webinars, but also, as we've said, we're really looking forward to being able to start some face-to-face meetings again, probably in the new year now. So with that, I'm going to close the meeting and thank everybody involved, both speakers and attendees, and we'll see you all again soon. Thank you very much.